The following program is brought to you by the Center for Educational Outreach at Baylor College of Medicine.
The title of my talk is The Importance of Sleep. And I feel by the fact that you actually came out at this time and are here and have given up your evening to hear me, you must have some feeling that sleep is important. Actually, when I give a similar lecture to the medical students, they have some doubts about why are we here hearing about sleep? Why don't we hear about the important things, the heart, the kidney, those important things? So I start out my lecture by showing this slide. I hope you can see this slide. And the question is, where won't a cat sleep? And of course the answer is anywhere, anytime. And if we were cats, of course we wouldn't have any sleep problems. We'd just sleep whenever we want. We'd sleep wherever we want, and our children would do the same. But we're not cats. And so we do have regular sleep habits, or we should, and we're confined by, we have to go to work, we have times when we sleep, and so sleep problems are a part of our life. That was very good. In addition, we know that sleep is essential, and I mean essential for living. In experiments in animals, when animals like mice are deprived of sleep, they, after a few days, get into a lot of troubles. Their temperature goes up, they become overheated, and they eventually die. These experiments haven't been carried out in humans, I'm glad to say that. Medical students never volunteer for those type of experiments, but we know what happens when people have been sleep deprived, and after a few days they become very confused and even approach psychosis. And so we know sleep is essential for just being alive. But I want to, in this talk, in this next hour, talk about more practical things, why sleep should be important to you, to your family, to your children. And so I'm going to start out with sort of David Letterman approach, the 10 top reasons that you should be thinking about sleep, that it's okay to talk about sleep with your pediatricians, your family physicians, and the reasons that they should be asking you how your children are sleeping, how you're sleeping. So reason number 1, actually reason number 10, we'll start at 10 as David Letterman does. Sleep problems are very common in children and teens. And indeed, when you look at children in general, typically and atypically developing children, a fifth to a quarter of all children have sleep problems that are persistent, that are problematic, that cause disturbances of nighttime sleeps that impact on their family. But when you look at atypically developing children, children with neurological problems, neurogenetic disorders, as many as 40 to 80%, and in some cases, depending on the underlying disorder, 100% of those children will have sleep problems. In addition, if you look at specific developmental problems like autism, the incidence of sleep problems is greater in those individuals with autism versus similarly intellectually impaired or developmentally impaired children. So there are more sleep problems in adolescents and young adults with severe autism than those individuals with severe developmental impairment without autism. High-functioning children with autism have more sleep problems than comparably high-functioning normal controls. And the normal IQ autistic children have significantly more problems than controls, again, with normal IQs. Reason number 9. Sleep problems are a common parent complaint. And actually, when you look at populations and look at the community samples, and you ask parents about what are the problems that their children have that they're most concerned about, the leading problems include illness, feeding problems, behavioral problems, physical abnormalities, and as the top problems. However, sleep is the next most commonly common complaint that we hear from parents, and that's before complaints about language problems, motor problems, developmental problems, and toileting problems and teething problems. And the latter two you would think would be very common, but they're less common than complaints about sleep. Reason number 8, childhood sleep problems are chronic. By that I mean they just are occurring one time a night, but frequently are occurring night after night after night. And the reasons for that are reasons common to children with neurodevelopmental problems. They include developmental delay, chronic illness, the presence of mothers having depression, and then family stress. All of these things are one or more of them are common to families with children who have neurodevelopmental problems. Reason number 7, sleep is necessary for children's best functioning. And we know there are a number of studies that support this and that give evidence to this, that if your sleep is disturbed, if a child's sleep is disturbed, if they don't get good quality sleep, if they don't get sufficient sleep at night, they have a number of problems that include mood problems such as irritability, problems with cognition such as inattention, learning problems or worsening of existing learning problems, and they have behavior problems or, again, worsening of behavior problems, including poor impulse control, overactivity. So all of these things happen as a consequence or are magnified in those children who have difficulty sleeping, who don't get sufficient sleep. Again, when we've looked at children with autism spectrum disorders and who have been enrolled in the Autism Treatment Network at Baylor College of Medicine, we have done a study looking at the impact of just having sleep problems and behavior. And we looked at a group of individuals who were 3 to about 18 years of age who had the diagnosis of autism spectrum disorder well established and who had behavioral problems well characterized, and who those families were given a validated sleep questionnaire to determine if they were having sleep problems. And this is the Child Sleep Habits Questionnaire. We looked initially at 54 children, and again, the problems were determined, whether they had sleep problems were determined by the answers to the sleep questionnaire. And we found that about 54% of the group that we were looking at with autism spectrum disorders endorsed sleep problems, significant sleep problems. However, the presence of those sleep problems, the magnitude of the abnormality of the sleep score indicating the sleep problems did not vary by intellectual level, IQ, by age, or by the specific type of autism spectrum disorder they had, or their socioeconomic status. What we did see is when we compared those children with autism spectrum disorder with sleep problems versus those without, that those with sleep problems had increased levels of irritability, hyperactivity, were more anxious, had more depression than those without sleep problems, and had more thought problems. In addition, those with sleep problems, in comparison to those children with autism spectrum disorders without sleep problems, had more problems with withdrawal, had more problems with aggressive behaviors, and had more problems with social interactions. So again, this is an indication that sleep problems will worsen behavior, impact on the overall development of a child. And again, to emphasize this, sleep affects all aspects of a child's development. Not only cognitive impairment, not only impairment of attention, academic performance is impaired, but in addition, children who have sleep problems have increased incidence of accidental injury, and also are at higher risk for impairment of cardiovascular function, immunological function, endocrine function. So sleep problems impact on all aspects of a child's development, whether it be cognition, whether it be other bodily systems are impacted in a negative way in those children who have sleep problems. Reason number 5 for thinking about sleep, for asking about sleep when you talk to your physicians, are the sleep problems of childhood impact on the family. And the impact is increased family stress and marital discord, poor family sleep, which will lead to daytime fatigue for parents, job loss. I can't tell you how often I was seeing a child who has sleep problems, significant sleep problems, where the mother has indicated she has had to quit her job because either she's falling asleep while driving to the job or while on the work. In addition, parents who have children with sleep problems and experiencing disruption of their own sleep because of that have decreased effectiveness with parenting. And this can lead, in some cases, when the problems are severe, to increase incidence of physical abuse of the child. So reason number 4, sleep problems exacerbate coexisting problems, whether they be medical problems, psychiatric problems, psychosocial problems, developmental problems. So if there are already pre-existing physical problems, medical problems that are going on, behavioral problems, these will be intensified, more problematic in those children who have sleep problems. Reason number 3, sleep is a public health issue. And by that, I want to emphasize these points. When a community sample of pediatricians was sampled, only about 20%, actually 20% did not screen for sleep problems. 25% did not screen for snoring. And actually, it is a recommendation by the Academy of Pediatrics that pediatricians should ask at all visits of all children, are they snoring, since this can be a sign for sleep-disordered breathing. And less than 40% of pediatricians are questioning teenagers on how they're sleeping. And if you think about your experience, your own experience as a teenager, as well if you have teenage children or know of teenage children, how many of them have sleep problems? And actually, it's almost like it's normal for teenagers to not sleep well, to have sleep problems. And finally, sleep problems in children present a significant financial burden to the general community, from the standpoint not only of the medical care that they're going to require, but the impact it has on family, job loss from family members, the impact on family dynamics. Reason number 2, and now coming to some of the most important reasons, pediatric sleep problems are treatable. And reason number 1, the sleep problems seen in children are preventable. And I'm going to talk about both of these as the talk goes on. What I'd like to now talk about is actually how we evaluate sleep problems and discuss some of the ways that we evaluate children for sleep problems, get into some aspects, what are the sleep problems that we see in children, but specifically, what are the problems that we see in children who have neurodevelopmental problems, genetic problems, and then finally, how do we treat those problems? What are specific treatments for the problems? And then the last aspect is, how do we prevent those problems from happening? How do we ensure good sleep habits, healthy sleep? So my approach is this sort of a 3-step approach. First of all, to identify and characterize the underlying sleep problem in itself. Then to identify if there are any contributing medical problems that might impact and worsen sleep for the child. And very importantly, understand from the parents what is their attitude, What is the impact of their child's sleep problem on the family? How are they coping with their child's sleep problem? What is their agenda? And when dealing with pediatrics, again, while the children are our primary patients, again, it's the whole family that we're really caring for if we're ever going to really help the children that we're caring for. So how do we evaluate sleep problems? There's sort of several approaches. The first approach are questionnaire-type approaches. And one questionnaire that I've found very helpful, and it's easy for pediatricians to do, for family care physicians to do, is called the BEARS. And the BEARS, actually, each letter of the word BEARS stands for a question that you can easily, that the physician can ask of the family. And actually asking these 5 questions gives more information than just asking an open-end question like, how's your child sleeping? And often some parents, especially parents of children where sleep problems are common, like children with developmental problems, will say they're sleeping as usual because they expect their child to have sleep difficulties, not to sleep well, that's just a part of their life. And so these questions actually get at the specific problems, and you can elaborate then if the answers are yes to these questions. So the first question is bedtime problems. Are the problems going to sleep, initiating sleep? The second is excessive daytime sleepiness. Is the child experiencing daytime sleepiness despite getting adequate sleep at night, or not getting adequate sleep at night? The third is A, for awakening during the night. What is the character of the awakenings? What are they associated with? What is the parental response to them? The R stands for regularity and duration of sleep. Is there a specific bedtime or out of bedtime? Is the child getting adequate amounts of sleep based on their age? And the final letter S is for snoring. And this helps identify are there breathing problems during sleep. These 5 questions can be easily given in a few minutes and actually get at the heart of sleep problems and allow you to go on to elaborate on them and to characterize sleep problems. A second approach is what we call a sleep diary, and this is an example of a sleep diary. What we ask is parents, and in some older children, teenage children who are able to do it, is record the time you get in bed, the time you go to sleep, the times you get out during the night, the time you get up in the morning, the time that you may or may not take naps. And this diary is interesting, actually. If you look here, this individual who's a teenager has a very regular bedtime. They go to bed at 10 o'clock, except on weekends, as teenagers sometimes do. They go to bed like at 1 a.m., and you may have teenagers who do that. But the important aspect is they're actually not going to sleep until much later. So they spend many hours in bed, text messaging, the computer, TV. You're very familiar with those things. And as many teenagers, go back, please. As in case of many teenagers, they have a delayed sleep phase. And so keeping this diary over a period of a couple of weeks allows us to identify the pattern of sleep and get at what the sleep problem might be. In this case, a delayed sleep phase. And the problem really is not the delayed sleep phase, but the fact that the child is getting up on school days, school mornings, at 7 a.m. or earlier because they've got to get to school. So this child, if they're going to sleep at 1 a.m., is probably getting only 6 or 7 hours of sleep, which is insufficient sleep. And so this child is sleeping during the day, as indicated here, is actually taking several naps or falling asleep during the day, and on weekends sleeping in to 12 o'clock in the afternoon. So sleep diary can be helpful in identifying the pattern of sleep, how regular it is, if there are awakenings during the night, and exactly what is going on. And these are very reliable at identifying this pattern. A fourth way is what is called actigraphy. As you can see, this is a watch-like device which can be worn on the wrist or can be worn on the ankle. And what it does is it measures movement. And every time the extremity moves, that's recorded and kept in the microcomputer that's in this watch. And the paradigm is when you download the watch to a computer, the paradigm is when you move, you're probably awake. When you're not moving, you're probably asleep. And so this actually gives the pattern of sleep in a very objective way, and this can be worn for days or even weeks, to look at the pattern of sleep over that period of time. It can't tell you the specific stages of sleep, but it gives you a very exact idea of what the pattern of sleep is. Is the individual getting adequate sleep? Are they going to bed at a regular time? Is the sleep pattern regular or irregular? Are they sleeping during the day? And the final way of evaluating sleep is what our gold standard. And we call it polysomnography, and it's usually called a sleep study. And it's demonstrated here. What a sleep study is, it can be done in the laboratory, and actually we can now do all these things at home and record it in the sort of home natural environment as well as this. But what it means is when we do a sleep study, we record many parameters, and we record them continuously from the time the child is put in bed to the time the child gets out of bed. So our sleep laboratory is set up to actually have a bed for the child, and in most cases we have a parent stay with the child so they feel comfortable about it. But as part of the sleep study, we're recording brain activity, we're recording eye movements, we're recording muscle activity from the chin. These parameters allow us to stage sleep and determine what type of sleep you're in, either in non-rapid eye movement sleep, which is sort of what we would consider the most relaxing type sleep, versus rapid eye movement sleep, which is the time that you would be dreaming, have your dreams type sleep. REM sleep is also thought to be important to learning as what its function might be. In addition to recording those parameters, the study records respiratory effort with airflow at the nose and mouth, with bands around the chest and abdomen for movement of the chest and abdomen, oxygen levels by we put a probe on the finger, and it's called an oximeter, and it measures the oxygen values throughout the night. We also have a probe to monitor carbon dioxide, which is the waste gas. We monitor leg movements. We put everything on videotape in case there are unusual things that happen during the night, and frequently there are. We can actually go back and look at the videotape as well as the record of the data that we've collected through the night. And we have a technologist in the laboratory who is constantly observing the patient, writing down notes so we know exactly what goes on. And so I always tell children and parents, we'll know exactly what you're dreaming and everything that's going on. But I won't know your dreams, but I will know if you are dreaming. But this, because we do everything continuously, we get a very good idea of what happens during the 8 or 9 hours when a child is sleeping in the laboratory. And you might think, well, with all these things on, it might be hard to sleep. Children actually sleep very well. The parents who are staying with them don't sleep very well. They're somewhat anxious about it. But we get a lot of data. We can tell the architecture of sleep. We can tell if there's sleep breathing problems. We can tell if there are abnormal movements. We can tell if there's seizure activity. And we can tell if the patients are getting adequate amounts of sleep and adequate amounts of the various types of sleep. So why would we do a sleep study? Why would we do this rather long, involved study, and it's somewhat costly? And there are several reasons that you actually do a sleep study, indications. So if your child is having snoring, breathing problems during sleep, this is the best way to quantify, to know exactly how severe the breathing problems are. This allows us also to titrate CPAP. CPAP is a device used to treat sleep apnea, primarily in adults, but also in children. It's a mask placed over the nose and mouth that delivers pressure to open up the airway. And some of you actually may know of or yourselves use CPAP for treatment of sleep apnea. In addition, we would do it if there are problems with daytime sleepiness. We want to know if the child is getting adequate sleep at night. Is the sleep pattern at night disrupted in any way, which would then predispose them to being sleepy during the day because they're not getting adequate or good sleep at night. We will also do the sleep study if there's suspicion of seizures or if we hear a history of unusual behaviors, if there's injury occurring during sleep, because this study will allow us to precisely characterize those behavioral events. And then if we suspect what are called PLMs, and those are periodic limb movements, so if they're repetitive, stereotypic limb movements, it allows us to quantitate them and determine are they associated with arousals. So these would be reasons that there would be indications for actually doing a sleep study on your child, or if you have these problems, for doing a sleep study for yourself. Well, when we do sleep studies in children who have neurodevelopmental problems, who have neurogenetic disorders, what do we find? What are the typical findings? And the typical findings are, first of all, you have to go back to the concept that your brain controls sleep. So in children who have neurological problems and often neurogenetic problems, often brain control of sleep is altered because brain function is altered or affected. So when we record these studies in children with these problems, they frequently will have poorly defined or absent sleep characteristics. The usual expected sleep characteristics that define non-REM or rapid eye movement sleep are frequently absent or not well defined. In addition, they often have reduced REM sleep. And again, REM sleep is important for learning. And so this is an important finding that in children who already have learning problems and developmental problems, that their REM sleep is reduced, so they're even at higher risk for having difficulties with learning. In addition, going to sleep actually enhances epileptiform abnormalities. Those are the abnormalities that were recorded on the EEG, the brain, the recording of brain activity that indicate a higher likelihood of having seizures, the so-called spikes or sharp waves. And they actually frequently increase during sleep. Sleep is a time when you're more vulnerable as far as having these abnormalities and having seizures. The incidence of periodic limb movement and sleep-disordered breathing, obstructive sleep apnea, is frequently a higher incidence in children with neurodevelopmental problems, neurological problems. So these are some of the typical findings of sleep studies performed in children with neurodevelopmental problems. I wanted to talk for a moment about what are the common sleep problems that we see in children with neurogenetic disorders, with neurodevelopmental problems. And I think they can fall into 4 categories. The first category is insomnia. And many of you, and probably most of you, are familiar with insomnia. Many of you probably have experienced insomnia. And it simply means difficulty going and staying asleep or experiencing early morning awakenings. These types of problems are very common for all groups, all categories, all kinds of neurodevelopmental problems that are seen in children. In addition, frequently these children experience awake sleep scheduling problems. They have delayed sleep onset, they have irregular sleep schedules, they have early morning awakenings. I wanted to give some examples of these 2 basic sleep problems, and one that I'm very familiar with because my experience with Rett syndrome occurs in girls with Rett syndrome. And currently we are funded by the NIH to do a natural history study of Rett syndrome, so some of this data comes from that study which we are performing and looking at children with Rett syndrome and with Angelman syndrome. And what we found is greater than 80% of girls with Rett syndrome have sleep problems. Those problems typically are problems going to sleep, about 30% of them, and then about 40 to 50% of them experience frequent awakenings, and about 18% have difficulty waking up in the morning. So the basic problems that occur very frequently in Rett syndrome are insomnia. Likewise, in children with Angelman syndrome, insomnia can be a very common problem. And I wanted to give you some of the information that we know about sleep problems in Angelman syndrome from the literature as well as from the natural history study that we are doing at this time. First of all, from the literature, sleep problems are frequently reported in children with Angelman syndrome, and the incidence varies anywhere from 40 to 100%. These are just a few of the studies that have been done. And the types of problems, again, the primary problems are those that would fit into the category of insomnia. They are reduced sleep time, settling problems or difficulties initiating sleep, night awakenings, early awakenings in the morning are the most common problems. Again, these are what define insomnia. We have done an initial study of about 102 children enrolled in the Angelman cohort of the natural history study. The ages of these individuals ranged from as young as 5 months to as old as 26 years, with a mean age of around 3 years. So these children were given questionnaires. The families completed the questionnaires that included questions about sleep, how their children were sleeping, as well as they underwent examinations, behavioral evaluations, and evaluation of the gene mutation. And I wanted to show you a graph. Again, we think of what are common problems in Angelman syndrome. Seizures are common problems. Inappropriate laughter sort of defines the syndrome. But these actually occur less frequently than sleep problems. So in this group that we've enrolled in the natural history study, actually nearly 80% had sleep problems, more than had seizures or inappropriate laughter, other features which actually define the syndrome of Angelman syndrome. So sleep problems include reduced need for sleep, frequent nighttime awakenings, and again, they're reported in as many as nearly 80%. We did not find a difference in those children reported to have sleep problems due to the underlying gene mutation. Has been reported in some cases that the sleep problems in Angelman syndrome are more frequent in younger children and may improve in childhood. Not all studies report that. Indeed, when we looked at our sample, we found it to be very common and became most common up between the ages of 3 to 5 years, but still remain very common. 70% of those individuals over 5 years continue to have sleep problems. So these problems do persist, are chronic in Angelman syndrome. Going back to what are the common problems that are sleep problems that are reported in children with neurodevelopmental problems, there are two other types that I wanted to touch upon. Sleep-disordered breathing occurs frequently in certain groups of children with neurodevelopmental problems, neurological problems, and also hypersomnia or excessive daytime sleepiness. This problem is either due to insufficient sleep. You would expect if you don't get enough sleep at night, one of the consequences are you're going to be sleepy during the day. But there are some children with neurodevelopmental disorders, neurogenetic disorders, that actually have the picture similar to narcolepsy, a primary sleep disorder associated with getting adequate sleep at night, but with excessive daytime sleepiness, with the tendency to go into periods of rapid eye movement or dream sleep during the day. And that would be inappropriate because actually when we nap during the day, we typically don't go into REM sleep. As examples of that, one example is children with Down syndrome are at high risk for sleep-disordered breathing, by which I mean obstructive sleep apnea, where there's actually blockage to the airflow when these children go to sleep. So what's happening when they go to sleep, their airway actually is collapsing down, becoming too narrow, either because of muscles relaxing, because they're hypotonic, because their airway is narrow to start with, because of abnormalities in facial development, muscle tone, or central control, brain control of muscle tone. In addition, they're like any other children, they can have large tonsils. And large tonsils can get in the way of the airway, especially when you go to sleep, muscles relax. So if you have large tonsils, they get in the way of airflow during sleep. So greater than 30% of children with Down syndrome are found to have obstructive sleep apnea. And the problem is that taking out tonsils helps a bit, but because of all the other features of Down syndrome, they continue to have sleep-disordered breathing, continue to have obstructive sleep apnea. And when you have this year after year, day after day, night after night, year after year, this can impact on heart function as well as blood pressure, and causes other cardiovascular problems that frequently see in adults. You can start seeing in young children with Down syndrome who have chronic obstructive sleep apnea. So this is important to identify, and the current recommendations are likely all children with Down syndrome should have at least one sleep study, if not repeated sleep studies, to identify the severity of sleep disordered breathing. An example, another example or another group of children who have significant sleep problems are children with Prader-Willi syndrome. And actually, these children have two types of sleep problems which seem to be independent. One doesn't cause the other. One is that they do have sleep disordered breathing. Many of the children tend to be overweight, in addition to have large tonsils, in addition to muscle tone problems. So the incidence of sleep disordered breathing, of obstructive sleep apnea, is increased in this group of patients. And so these patients should, when they have symptoms of snoring, when there's any question about how they're breathing at night, undergo sleep studies to define the severity of sleep-related breathing problems. In addition, independently from this, many of these children have excessive daytime sleepiness, and they can have even features that look like they have narcolepsy. And this seems to be a very specific problem to Prader-Willi syndrome. So when we looked at the patients that we've seen with Prader-Willi syndrome, we found that 70% of them actually had obstructive sleep apnea. A higher number of them were having problems with maintaining oxygen levels, which are necessary for functioning of the brain and heart and other body organs. And many of them were retaining the waste gas, which can indeed be detrimental to the functioning of the lungs as well as to other body organ systems. In our group of patients, which about a quarter of them, 25% of them, actually had findings that mimic narcolepsy. During the nighttime study, they got appropriate amounts of sleep, but during the day they were falling asleep at inappropriate times. When given the opportunity to nap, they would very quickly fall asleep, and they would enter periods of rapid eye movement or dream sleep during those nap sessions, which is characteristic of narcolepsy and is not characteristic of typical children who nap, do not enter into REM sleep. The next component of the evaluation that I wanted to touch upon is you need to evaluate for medical problems. And again, a number of medical problems can impact on sleep. And many of them, actually, the medical problems are more severe or more frequent during the time you're asleep. Those include gastrointestinal problems such as gastroesophageal reflux, GERD, constipation. Those problems are intensified because of the physiology of the GI tract and changes that occur during sleep. You're more likely to get into trouble with acid reflux when you lay down, when you go to sleep. Medications of all types can impact on sleep. And so I have to make an aside comments here. Medications include things maybe we don't think as being medications. They include all the soft drinks we drink, which include caffeine. And we find that we're a nation that likes to have our coffee or soft drinks, and this goes for not only adults but children and teenagers who know if they use these drinks that the caffeine will help them keep awake because we have a society that's at high risk for insufficient sleep, for daytime sleepiness. Medications include things like alcohol. For adults, often use alcohol to induce sleep, but this is not very good because while it makes you sleepy, it actually doesn't promote good sleep. It actually, the sleep that you get is is an abnormal sleep without adequate amounts of REM sleep. But you have to remember, alcohols and a lot of medications that you can buy over the counter or that are prescribed and given to your children, so that can impact on sleep. In fact, another drug that we might not be thinking about is tobacco. Many parents smoke, and secondhand tobacco actually has been shown to impact on sleep not only of the parents but also the children, and causes poor sleep, disrupts sleep, and those children who are in families where parents are smoking or teenagers who are smoking themselves have poorer sleep than in non-smoking families, non-smoking individuals. Children who have attention problems, who have underlying behavioral, psychiatric problems, are more prone to have sleep, disturbed sleep, and you really have to address these issues if you are going to improve sleep. Again, when we looked at the rare disease study for Angelman syndrome, we looked at the occurrence of sleep problems in reference to other problems that the Angelman children, individuals, were having. Those children who were having seizures more frequently had sleep problems than those children who did not have sleep problems but who had Angelman syndrome. Likewise, those children with Angelman syndrome who had symptoms of gastroesophageal reflux, of acid reflux, were more likely to have sleep problems, 80%, versus just reflux alone. Those children who had no reflux had fewer sleep problems. So the issue of medical problems needs to be addressed because things we would do for sleep problems won't cure these medical problems. You have to take care of the medical problems if you're going to improve sleep, if you're going to really address the sleep issues. And again, the last component of evaluation is determining the parent attitude, the agenda that you have, the impact that sleep problems have on your family. And importantly, we'd like to know, how do you respond when your child wakes up? And is that response appropriate, and does it reinforce behaviors that we like not to see? For example, one of the major problems that we deal with all children, especially young children, is all children, in fact all adults, experience awakenings at night. And the real problem is how they are able to put themselves back to sleep. So remember, some children learn to go back to sleep because they are being rocked, they are being given a bottle, they're being put in a car and driven around until they go to sleep. They learn, they go to sleep under those conditions. And that would be okay, except that disturbs your sleep. Parents don't get a good sleep because they got to get up and repeat those behaviors. So you want to know what the response is, what parents do in response to their children waking up, not maintaining sleep well. What are the goals of parents? What are their hopes? Are they realistic goals do you have in mind? You know, for some children, going to bed at 8 o'clock, sleeping through the night, getting up at 7 o'clock might be a realistic goal. But for a teenager, that's never going to happen. And so you have to set realistic goals, what can actually you can be expected to happen, accomplish as far as sleep. How are they coping? And these last two issues are how parents are coping and the potential, are they at wit's end? Again, the potential for harm. Has the problem been to such an extent that now they are sleep deprived and experiencing problems with insufficient sleep, and the impact on the family? This determines, it tells me, planning the intervention. Is it to the point where something has to be done right away, or do we have time to initiate a behavioral program that's going to take some time? So these are important issues in determining the type of intervention, the acuity of the intervention, the character of the intervention you're going to do. And so parents play a very important role in the plan. They're part of the team here in determining what is going to be the plan for management of sleep problems. So again, how do you manage the problems? We want to treat the medical problems. We want to manage the daytime behavioral problems, resolve those issues. We want to review and change medications as needed to make sure that they're not impacting in a negative way on sleep. Eliminate medications which may have the impact of causing sleepiness, or which, on the other hand, may interfere with sleep, make it difficult to go to sleep. And then we want to give information and make reasonable goals so parents have a plan that's reasonable, that can be carried out, that will work for their family. Part 2 is treat the underlying sleep problems, such as obstructive sleep apnea. Provide information about sleep hygiene, things you can do to improve your child's sleep, prevent problems from happening, improve the quality of sleep. We use behavioral approaches as a primary approach to treating insomnia. As in adults, we also do that in children, but in certain situations, especially if the problem is an acute problem, is a very severe problem, we will use medications to treat certain types of sleep problems, and specifically insomnia. So again, specifically for for the 4 major categories of sleep problems that I mentioned, for insomnia, our primary approach is a behavioral intervention, but we also have promote good sleep hygiene, improving the sleep quality, and then as another alternative in certain situations, use what we call hypnotics or medications that induce sleep. For those children experiencing hypersomnia, again, we want to identify, is the problem insufficient sleep at night? So we'll do behavioral techniques, things to improve the quantity as well as the quality of sleep at night in those cases. But in the cases of children who are getting adequate sleep at night but are having difficulties with excessive daytime sleepiness, such as individuals with Prader-Willi syndrome, they will use drugs that are alerting type drugs, stimulant type drugs that will maintain and promote alertness during the day. For sleep-disordered breathing, specifically for obstructive sleep apnea, in children, frequently we'll go to tonsillectomy and adenoidectomy because this can be curative of the problem. In many children, it resolves obstructive sleep apnea. For those children that it doesn't, we can use what is called CPAP, again, a mask-like device that delivers pressure to keep the airway open throughout the night, that you wear all the time that you're sleeping. Sleep positioning, sometimes obstructive sleep apnea is worse on your back, so just having the child sleep on their side. And we can do this inexpensively. We just have you sew a tennis ball on the back of a shirt that your child wears at night, or you can go to a medical supply store and pay $50 to $100 for a similar device. So you can do the simple device and keep the child, maintain them on their side. And the thinking is, if you roll on your back with a tennis ball on their back, it will feel very uncomfortable, so you will roll back on your side. Weight management in those children who are overweight, obese, and this is now a very frequent problem of all children that we see. Weight management programs to maintain weight so there's not more excessive weight gain, or actually to lose weight may be indicated. And in the special case of Prader-Willi syndrome, growth hormone has been very helpful in actually promoting lean body weight and promoting weight loss or appropriate weight gain. There was concern that growth hormone therapy in Prader-Willi syndrome might be associated with sudden death. And actually, when we reviewed the cases, these were cases of children who had severe sleep apnea. It wasn't the growth hormone that was related to death. It was the fact that they had severe sleep apnea, which was affecting lung and heart functioning and predisposed them to death. So growth hormone actually, we found, can actually promote and promote the cure, maybe not the cure, but improvement in sleep-disordered breathing, specifically in Prader-Willi syndrome. What I want to talk about are dealing with insomnia. And one of the things you need to know is, what is enough sleep? How much is enough sleep? And actually, it's very basic. You have gotten enough sleep for anyone, an adult, a child, typically developing child with neurodevelopmental problems, if you feel well rested, which means that during the day you're functioning at your best. You're alert during the classroom. You can do the lessons appropriately, carry out therapies. The amount of sleep is age dependent, and so the amount of sleep that is required at young ages is much more than might be required in older children. But the bottom line is each child is different. So some children may require 10 hours of sleep and do very well and function normally on that. Other children may require only 7 hours of sleep. And so those differences have to be kept in mind when we're evaluating children and proposing programs to help with sleep problems. This is just some guidelines at various ages, what the requirements are that have been determined for typically developing children. In newborns up to about 2 months of age, the typical requirement is 16 to 20 hours of sleep during the total day. So there's no like nighttime sleep, daytime alertness, naps. Very young children sleep like 4 hours awake, a couple of hours, sleep 4 hours, and so forth. As they get older, sleep is consolidated at night, and so that in children around 12 months of age, 9 to 12 hours of sleep with several daytime naps are the normal, and so forth. And the point I want to emphasize is, even though older children need less sleep, teenagers are still requiring, and typically developing teenagers, they're requiring 9 to 10 hours of sleep to be fully alert, functioning during the day. So as the example I gave you with the child who was going to sleep at 1 a.m. and getting up at 7, getting only 6 hours of sleep, every night they were having a 3 to 4 hour sleep debt, which builds up by the end of the week. They have a 15-hour debt, which they can't make up. So even teenagers still are requiring 9 hours of sleep to be functioning in an appropriate way. As I've been emphasizing, these are the numbers of requirements of sleep required by typically developing children. It appears that children with neurodevelopmental problems may require less sleep, but there haven't been good studies to tell us what those numbers are. So I think these are good ballpark numbers to keep in mind for your pediatrician, for you to keep in mind as your child actually getting these basic requirements, and if they're not, they may not be getting sufficient sleep, that indeed they may be having a sleep problem that may need to be addressed. The other thing was how many awakenings at night are too many, and what kind of numbers to use as you're evaluating a child. Again, it's actually natural for all of us to wake at night for very brief periods of time, but then to be able to put us to sleep. So if the frequency of awakenings are more than 3 or 4 per night, that should cause concern. If the duration of any one awakening is greater than 20 minutes, that should cause concern. If the awakening requires parental intervention, that should cause concern. And when I say it should cause concern, it would be okay for you to tell your pediatrician, my child is not sleeping well, they're waking up a lot, it's requiring my intervention, disturbing my sleep. If the awakenings are associated with snoring, which can be a sign of sleep-disordered breathing, obstructive sleep apnea, if it's associated with frequent movements, injurious behavior, stereotypic behaviors, which might be indications of seizures, if your child is sleepy during the day and experiencing waking at nights, those are times when it's okay to be concerned. It's okay to mention this to the pediatrician. It is right to bring it up and discuss sleep with the family physician or with the sleep specialist and see what the sleep problem might be and what needs to be done. we have numerous types of behavioral treatments, and I'm really happy because most of you have become familiar with it because you have the opportunity to watch The Nanny. And I don't mean the nanny of long ago, I mean the current nanny who goes to the house and straightens up the house. And she uses these same techniques. So like, these are not like special or anything like special that I'm telling you about. They're well known to psychologists, to nannies, and actually well known to parents who read books by Dr. Ferber and have Ferbered their child, and these are these techniques. And essentially, these behavioral techniques, first of all, include extinction, or this is the so-called crying it out, where the child is waking up, really not in trouble, they're just waking up and they're trying to get parents' attention, getting rewarded for the arousals, getting feedback of a positive nature, so they keep awake. And what you do is you don't respond at all. The child may cry, but you don't go in. You are able to identify if the child is really having an emergent problem that needs attention, but in most cases it's merely attention-getting type crying, so you let the child cry. This is quite difficult for many parents because it does take several nights before the crying stops, and those nights are very difficult nights, hearing a child crying often for long periods of time. So we use the so-called Ferber technique, or graduated extinction, where there's graduated waiting times before you go in. So what this is, if the child awakens and signals to the parents by crying, yelling out, doing things that arouse the parents, you don't go in immediately. You wait a specific amount of time, like a few minutes, like 2 or 3 minutes by the clock. You go in, check the child. That's it. You just say good night, leave the room. If the child continues to signal, instead of waiting 2 minutes, you now wait 5 minutes. You go in and do the same thing. You continue to do this until the child goes back to sleep. And then if the child awakens later in the night, you repeat this over. These techniques are proven to work. They are safe techniques. They don't have negative psychological impact on the child. Indeed, children who undergo these therapies actually do better than children who do not have these therapies done to improve their sleep. The third one is really the nanny technique, and that's where the parent sits in the room but doesn't interact with the child. The child may signal to the parent, call to the parent, cry to the parent. The parent is sitting there. If the child is really in trouble, they're there to help them, but they don't have any other interactions. And then night by night, the parent moves towards the door to go out of the room, and finally goes out of the room and slowly extinguish any interactions or the presence of the parent, and extinguishes the behavior. Another technique, and this may sound like a little weird, but actually if the awakenings sometimes are predictable, you know your child's going to wake up at this time or this time. If you have scheduled awakenings, you go in, and before they get a chance to awaken, you awaken them briefly and then allow them to go back to sleep. You can abort the prolonged awakenings and actually reverse these behaviors and as the other techniques treat the insomnia. So again, all of these techniques have been proven to work, are effective, are safe. The way they work, though, is being consistent with them. The first time, if you're doing extinction, the crying out method, the first time the grandmother goes in there, picks up the child, you start all over again. You go back to point zero. So everybody has to be on board for it, and you have to be consistent, matter of fact about it, and to continue to do this. And usually I tell parents, initiate these types of interventions on the weekend so that you can get enough sleep, because these are going to be the worst nights, even worse than you've had, because the sleep will be more disturbed when you start these. But these do work, and they work fairly quickly. And frequently when I outline these plans and have parents do it, when I tell them to come back in a month, they don't come back because it's worked and their children are sleeping and there's no reason for them to come back. Other things that work are really educating parents about what are expectations as far as awakenings, expectations about the amount of sleep, what represents good sleep. Relaxation therapy, and for some individuals this are programs of heavy breathing, repetitive breathing, but for many children with neurological problems, neurodevelopmental problems, massage therapy actually is quite helpful. Relaxing type therapy is quite helpful for children who are experiencing insomnia. In adults and in some older children, we do two other types of therapies. And these are going to sound a little weird to you, but I'll tell you about them. One is called sleep restriction. It's based on the principle it's better to spend the time you're in bed asleep, be more efficient about that, than spend long times in bed awake. So in many cases, especially in adults, we'll hear stories that they go to bed at 10, but it takes them an hour or two to go to wake. So they're really not going to sleep until 11 or 12 o'clock. So what I'll do in the case of teenagers who present me with this story is say, we're going to change your bedtime. You're not going to bed at 10 o'clock, go to bed at 12, because you're more likely to go to sleep then. And when you're going to sleep and staying asleep for a certain period of time, we will move the bedtime back. And gradually you increase the amount of time they spend asleep in bed. And this actually is a very effective therapy for insomnia. Stimulus control therapy, again, is based on this principle. Many patients who have insomnia, this includes children as well as adults, will spend long times in bed thinking about things like, I can't go to sleep, it's getting later, looking at the clock, oh, it's now 2 a.m., I only have 4 hours to sleep. And so you try to reduce all of those kind of negative input. And you tell them, get the clocks out of the room, no clocks in the room. If you're awake for more than 10 or 15 minutes, get out of bed, go to another room that's dimly lit, nothing going on that's rather dull. When you get drowsy and ready to go to sleep, come back to bed. Again, these two therapies are based on the principle it's better to spend your time asleep in bed than long periods of awake, which you get into a vicious type of cycle. You can't sleep, that in turn you can't sleep even less well. Those are the behavioral approaches to insomnia. Again, they have been proven to be effective, to work, and to be carried out without any negative consequences. And many parents are concerned in doing programs of extinction or graduated extinction that it could be harmful to the psychological development and cause problems, but actually it's quite the opposite. As being helpful for improving sleep, it's also for helpful improving behavioral as well. In certain cases, though, medications are indicated. Those indications are when the problems are severe, they have a very severe impact on the family. Parents are terribly sleep deprived because their children are having severe sleep problems. And in the case of many children with neurodevelopmental problems who in many cases, those behavioral problems that I've talked about aren't completely effective because they are able on a cognitive basis to get full value of the behavioral programs. We will use medications. The problem in children, in contrast to adults, there are no approved medications for sleep in children. Moreover, there are very few, if any, studies that have looked at the efficacy, how effective medications might be for inducing sleep, how safe they might be, how can they be used chronically or only on a one-time basis. We don't have those studies. So often we're reduced to using drugs that we use in adults, or in many cases using drugs that we know are used for other reasons, but as a side effect cause children to be sleepy. The other point is medications, even though we don't have this information, even though there are no approved drugs, medications are frequently used by pediatricians, family physicians, either ordering by prescription or by telling parents to go out and buy an over-the-counter medicine like Benadryl, which is not an appropriate medication, one that I'm not going to tell you to use. And so medications are frequently used. In a survey of community pediatricians, more than 50% of them had prescribed a medicine for sleep within the last month. Some of the medications that we have that are used to treat sleep problems, specifically insomnia, to induce sleep, which are actually acting as though they're hypnotics, are listed here. Many of these medications, actually, their primary use is not sleep, but for other indications. For example, clonidine is actually an antihypertensive, anti-high blood pressure medication. But one of its side effects is it causes people to be drowsy, and so it has been useful in many children, especially children with neurodevelopmental problems, with behavioral issues, to induce sleep. There are certain medications called hypnotics which were made specifically for sleep. And zolpidem is actually ambient, and there are other generic drugs like Rosarum, which you may be familiar with, which are commonly used in adults and have been shown to be effective in adults, which we may use especially in older children, teenage children. Ambient that I've listed here is of interest because it comes in a short-acting form and a CR, or long-acting form, which if you give a dose at the beginning of sleep, it should have duration, action throughout sleep. The one problem with Ambien has been it tends to induce behaviors like sleepwalking and night terrors, especially in young children more frequently than in adults. Certain antidepressants have been used, and one that I use frequently is trazodone. One, because it's not a very good antidepressant because it really causes you to be sleepy, but it's a good medicine for sleep because it causes you to be sleepy, and it's fairly effective, and it generally is safe. It doesn't have much carryover effect during the daytime, which is a concern for many of these drugs which have long duration of action. Melatonin I'd like to come back to in just a moment. Risperidol is a medication primarily given for behaviors and which has been effective, especially in children with autism, given at night in helping them sleep. And it may just act mainly as medicine control adverse types of behaviors. I wanted to touch upon melatonin because it's very popular, because you don't have to have a prescription for it. You can go to the drugstore, to Target, to your health food store and buy it without prescription. It releases. And what happens is when you're awake during the daytime, when it's light, your melatonin levels are low. When it becomes night, melatonin goes up. And actually, when it becomes night, you typically go to sleep. So the thinking is, if you give melatonin, it may help to induce sleep. The real story is melatonin probably is a hormone that tells you the changes in seasons. It's really helpful for lower mammals like mice who have to reproduce at certain times during the season and have to forage for food at certain times. But it's still excreted in humans on this diurnal variation, by which I mean daytime low melatonin, nighttime high melatonin, and so happens that we tend to sleep at night. And so melatonin has been given to adults and children with neurodevelopmental problems to induce sleep. And there have been a few studies. They have not been large studies, they have not been very good studies, but they have shown that in children with neurogenetic disorders that melatonin given in this dosage, which is not a very high dosage, of 5 or 2.5 milligrams at bedtime, will help advance the sleep onset. So you go to sleep at an earlier time. It decreases the time to go to sleep, that's sleep latency. It increases total sleep time, and it increases nighttime awakenings. This doesn't happen in every child who takes melatonin, but in a number of children who take melatonin, it does have benefit. And the risks are fairly low, and in fact it's essentially a no-risk drug at these types of dosages. There have been some concern melatonin given in pubertal children may affect puberty and and hormones that are important for sexual maturation. There has been no proof of this. There has been some concern that some children with seizures might have seizures worsen with melatonin, but again, there have been really no studies proving this. So I frequently use melatonin. It appears to be a safe drug, and it's a drug that many sleep physicians use. Furthermore, there has been growing interest in looking at melatonin levels in children with neurodevelopmental problems. And one of the research projects that Dr. Pataki and I have been involved with is looking at the Smith-Magenis syndrome, a neurogenetic syndrome which is frequently associated with behavior problems and sleep problems. And what we learned was that those children, rather than releasing melatonin at night, release melatonin during the daytime. And one of the treatment approaches have been to try to reverse that and give them drugs that would inhibit melatonin release in the day and give them melatonin at night. And in one study, a couple of studies that have been done, that treatment has actually been associated with not only improvement in sleep, but improvement in behavior during the day. There's a growing interest in looking at melatonin, and there may be abnormalities in melatonin in a variety of neurogenetic disorders. So this story is not over yet, and certainly, again, the studies of use of melatonin are small, and further studies need to be done. So the last theme I want to give is what you can do so you can prevent sleep problems and improve sleep. And again, my point of view about life in general is that sleep is one of the three pillars that are important for healthy life. And that includes diet and exercise. And sleep is as important as those. And if you don't have a good combination of all three, you can't have a healthy life. So to promote healthy sleep, we do things that are called promoting sleep hygiene, things that promote good sleep quality. And these are things you can do for your family, for yourself, for your children with neurodevelopmental problems that will promote their sleep. Their healthy sleep, their good sleep, and so they go to good night's sleep. Again, we have to remember that the amount of sleep that children need depends on age, developmental status, but even older children, teenagers, still require as much as 9 hours of sleep to function in a normal way during the daytime. Children and adults should probably have some routine they do every night before they go to bed. And I think this is especially important for children with neurodevelopmental problems. Routine, which is the same night after night, is the clue, is the stimulus for telling them we're going to go to bed, we're going to go to sleep. And that routine might be taking a bath, it might be reading a story, it might be listening to calming music. It is important that children, and as well as adults, go to bed awake but ready to go to sleep. If you go to bed on the couch, if you wake up at night, you'll have to get on the couch to go back to sleep. That's where you learn to go to sleep. So put children awake but ready to go to sleep when they go to bed. The bedtime, the out-of-bed time, should be very regular night after night, and that includes a Monday night as well as a Friday night and a Saturday night for all children. This is especially important for children with neurodevelopmental problems. The time of the naps, when they're appropriate, should be the same day after day. Studies have indicated, certainly in adults, elderly adults, when the schedule is very regular, the 24-hour schedule is very regular, they get up at a certain time, breakfast at a certain time, they do these activities at a certain time, they go to bed at a certain time, very regular, it helps them to get a better night's sleep and to function during the day. We have long known this is true also for children with neurodevelopmental problems. They do better with that very strict, regular schedule. And so I think that is a very important aspect of good sleep hygiene. The bedroom should be dark, but they can have a night light, low voltage, like 40 watts or something. That is okay. It should be cool. Remember, as you're going to sleep, one thing that happens to your body and to your brain is that your body temperature falls, and that's actually a signal to your brain to go to sleep. This is why a warm bath before you go to bed works, because when you get out of the warm bath, you cool down, and that's a signal to your brain to go to sleep. So the room should be cool, and an overly warm room it does not promote sleep. A cool room actually promotes sleep. For these children, it should be a safe environment. So if they're getting up at night, you don't have to wake up. You have to lie awake at night wondering, are they safe in the room? And show that it should be a safe room. For children, one of the biggest reasons that all children, whether they be age 2 years or 16 years, don't sleep at night, don't get adequate sleep, are electronic media. They're watching TV, they're on their computers, they're on their cell phones, text messaging. And you may not realize that, but actually when I talk to in interviewing families, I not only ask the parents about children's sleep, I ask the teenagers, what are you doing at night? And they're quite upfront about what they're doing. These need to be out of the room so they're not being used. Certainly your child could use a computer if they can and are allowed to do that, but it should probably be out of the room. So we want bedrooms to be media-free. The one thing that children do in their bed, the only thing, is sleep. A pre-bedtime meal is okay. It should be quite light, and of course caffeine should be avoided. Certainly if you're having sleep problems, all caffeine should be avoided. Caffeine after the noon meal should definitely be avoided. Alcohol, remember, alcohol again is in certain medications, even those you get over the counter, and try to avoid those. You would think doing a lot of exercising before you go to bed would help induce sleep, but it's quite the opposite. This is actually activating of the brain and keeps you awake. So exercising should be done many hours before your actual bedtime. And so this means, practically, parents who are coming home at work and want to interact with their children should be playing games and doing things with them in the early evening, and in the later evening there should be a quieting down time and not a time of strenuous play. This also means, often I say, take a warm bath before you go to bed because it promotes sleep. But in case of many children, bath time is like fun time, like play time, and it's very activating, so we often have to reserve the bath for up in the morning time. And finally, remember, light is your friend as far as sleep. A lot of bright light in the morning, this means like turning on all the lights in the house, will promote an earlier bedtime. A lot of light in the evening promotes a later bedtime. So you can use light for yourself, for your children, if you're traveling, to actually regulate the time you go to sleep, the time that you're getting up. So these are my suggestions about not only how to manage sleep problems, but how to improve sleep, how to promote good quality of sleep. And this brings me to the end of the lecture, and I want to thank you all and wish you all a good night's sleep. Thank you.